Great. I think I did it right. Since you went mute, I'm gonna assume that went well, Mary. So thanks
Yes.
everybody for joining. Appreciate it. Thanks. Starting right at the 2 o'clock hour. I'm Keith Grahams. I'm the chair of emergency medicine up in Rochester, about 6 hours outside of the city, but Rochester Regional Health. And we get a chance to talk about New York State mandates, including iStop and some of the other fun stuff that we worked with along the way. Before I jump into that, we definitely want to ensure that we provide proper thanks to SAMHSA. Really, thanks to their funding for this endeavor. And really, without their support, we would not be able to do great things like this and provide some of these kind of educational endeavors, if you will. Also, want to take an opportunity to point out a great resource. That's the Opiate Response Network. They are basically available to provide education, training. You can reach out to them. I highly encourage you, if you have a question or anything along the way, reach out to them. Wait 1 second, and here is their contact information, everything from the email to their website. Of course, if you want to make a phone call, even got a phone number there for you. So, again, reach out to them. They're a great resource during some of these endeavors at your locations potentially. Just a quick reminder or a quick heads up. We're probably going to try to keep most of the questions at the end of the presentation. It's a little tough to keep track of chat and all that kind of stuff along the way. And with that, we'll go ahead and jump on in. I always like to lead my presentations with a few disclaimers, just so that you guys know what you're kind of in for the next 45 to 60 minutes here. I am a numbers guy. I'm going to throw a fair bit of numbers at you because I think that's relatively important for our practice and how we take care of things. Don't try to get too in the weeds with the numbers. I'm mainly trying to really talk about some of the topics here and some of the issues that we were working with. Some of the stuff that we're going to talk about along the way, you're going to sit there and think, man, Keith is crazy. That's okay. I know it. We are paranoid about these kind of things. We want to make sure we're doing the right things for patients. We really want to kind of head off the things at the pass. And some of the stuff that we did probably was a little bit in depth, maybe a little bit too crazy. But between our numbers, as well as our paranoia, I'm sure there's a DSM-4 or DSM-5, whatever level we are in with regards to a diagnosis there. I wouldn't necessarily ascribe us as experts, but we have made probably almost every mistake that we can kind of along the way. So we've made plenty of them. Along the pathway, we've figured out a couple of different things. This is a completely new environment. This is the only time I'm going to mention the word COVID, thankfully, in this presentation. It is very odd talking to a computer. I know we're kind of probably, if you're like me, you're probably doing a couple of things on the sides. As we're walking through this presentation and going through this. So I want to try to keep you a little entertained. We got to keep you engaged here. We're going to throw some different things. We're going to throw some pictures at you, and really just try to keep this a little bit more entertaining as we go along. And with that, I'll also follow my main rule that if you have not struck oil after 45 minutes, I'm going to work to stop boring. Yeah, talking to a computer, can't hear anything. So with that, I want to kind of just lay out our agenda. We're going to talk about the New York State mandates, of course, and we have that little red action required stamp on those. But as we were talking about the mandates, or as I was kind of looking at this, I thought it might be a little bit more interesting to talk about the mandates in light of what we're doing locally within our organization, and with that, kind of showing what we did kind of along the way. As we do that, I'm going to talk about something about stages. You know what that means here in a little bit. But really, with each year, we actually had a different process. And like any type of PDSA cycle or process improvement cycle, we were making these stepwise adjustments along the way. So I'm going to talk about those different adjustments each year that will also coincide with the New York State mandate that came, and then show you the results that we saw with our system during that year. And all in all, hopefully we can actually come up with a suggested system approach. I'm sure all of us are working on this at certain levels. Some of you even maybe much farther along the way. But as we go along here, maybe get a couple ideas as we take a look at this. So for those of you familiar with New York State, these are no surprise. For those outside New York State, I'm sure you might be dealing with some of these things or have dealt with some of these things. But these are really our three main mandates that kind of hit us in our state. The iStop, of course, the prescription monitoring program back in 2013. The electronic prescribing really came to fruition in 2016. Mandatory prescriber education, that was a little bit of an interesting kind of update in 2017. Really, I'll give you the spoiler. I don't think it did a whole lot for our prescribing practices other than just kind of help provide some education that we were working internally as a group. And then for those of you who really want to dig in, do a little bit more, The notable others that were much more indirect, at least for emergency medicine, were the written treatment plan that came in 18 and then the opiate excise tax. So with that, I'm kind of going to give you the layout here of how we're going to kind of talk about the story. And with your permission, I guess since you're muted, so with or without your permission, we're going to kind of go along this way. So what I have for you is a relatively large graph. I'll just give you a quick parameters here. And what I have is that blue bubble, which is going to be a veil that we're going to peel over the years to kind of just show you our progress. And rather than giving you a year by year by year different graphs and have to keep readjusting and figuring out the x-axis, I just kind of gave you the big one right here. And when we took a look at our initial narcotic utilization back, it was really late 2012, early 2013, we basically had a number kind of in the range of about 20.6. And that I'll keep basically describing this in 20.6, and that's scripts per 100 visits. So at the time, we were like, well, is that a lot? Is that a little? We don't really know. There wasn't a lot of comparison groups that we can kind of take a look at. We only knew some bits and pieces along the way. But as we were working as a group and taking a look at this, we did notice that, okay, 20.6 scripts per 100 visits. Let's just break down some numbers. We had about 7,400 visits that month. That's about 1,700 scripts. We put out almost 33,000 pills. Now, that is essentially a single month. To me, that initially felt like a lot. And if you break it down, that's about 19 pills a visit. 19 pills a script and about 4 pills a visit or so. So as we are looking at this, we're trying to figure, hey, this is a lot, is this a little? And the fun part about this, you initially take it to the group, and we kind of discuss this as a group. And the fun part about it, when you take this initial piece of information, we put out 33,000 pills in January of 2012. Hey, guys, what do you think we can do to kind of start bringing this down? So the fun part about it, at least in my experience, when you throw out something like this to the team, you got some initial kind of tidbits that kind of start coming back your way. And of course, the initial response, you got about 7 or 8 members of the team here. They start thinking, and where their mind starts going. So 33,000 pills, you know what? That sounds like a lot, but I'm sure I'm not the issue, because you know what? Every time I write a prescription, every time I write an opiate, I am completely justified by the way I do it. And you know what? It's not me. It's probably Dr. So-and-so, my colleague. I heard they're the candy man. No, it's not me. There's no way it can be me. But you know what, Keith? I can't believe that you're even talking about this kind of stuff. You sit us in front of a computer. You've taken away all my ability to provide patient care. Why are we even talking about narcotics? This is unacceptable. You need to let me take care of patients and stop getting in my hair. Well, what if you go ahead and start talking to the PCPs first, the primary care physicians and the specialists? Because as you know, Keith, only 4% of scripts are basically coming out of the emergency departments. Well, this is just another mandate, and I don't understand why we have to keep living through this over and over and over again. But you know what? This might, he did say there was 33,000 pills, and it's kind of tough to argue that. That sounds like it might be a lot. And you know what? There's probably some stuff that we can do. So I know you all know these stages. These, of course, are the stages of data grief. I enjoy these stages even now to this day. Even some of the newer projects, or when we're actually taking a look at some of the initial data regarding things, or regarding those new projects, I will find others, and you can even identify where they are along that stage. And I think it's one of those things where the faster we get to acceptance with some of this stuff, the better it is for us and for our teams, and then ultimately often for our patients. Of course, if you're working with clean data and right data. So when we took a look at this initial 33,000 pills, it felt like we had a lot of people pointing fingers at us. We live pretty much in a pretty big fishbowl, at least in the emergency department. A lot of people can see what we do as far as the clinical documentation or the claims and all those kind of things. And there was a lot of fingers pointing at the ED for starting people on narcotics unnecessarily, and we needed to do something about it. And we got that initial defensive mechanism. We got that initial denial that was started to push back on this. But again, when we started looking at it, that 33,000 felt like a lot. And we thought, you know what? We see a lot of patients, but there's probably something we can do. So we got to acceptance relatively quick. And we knew we had all these different anecdotes. And we realized really quickly that those anecdotes were driving things faster than sometimes even some of the reality of the situation. And the anecdote didn't always necessarily have the whole picture in place. And of course, the plural anecdote, that's not data. And we realize that we can actually help describe our fate. We can actually help create where this is going to go. And rather than sit back and be defensive and denial and maybe into the anger stage, let's go ahead and start playing with this and getting into this and grabbing this by the horns. And let's use that data as a shield and or use our process and getting that data to help kind of protect us along the way. As we were taking a look at this, members of our team thought we were a little nuts taking a look at this. And actually, figuratively, a remaining house of medicine essentially kind of stayed on that iceberg. They didn't do anything, and we were that kind of that lone service initially, at least in our local location, that jumped out there and really kind of jumped into that water. So we didn't know exactly where this was going to go, but we thought it was the right thing to do for patients, and we just want to make sure, hopefully, we didn't jump in that water and there was, an orca or a great white or something ready to get at us. So again, story starting back in 2013. We did very basic things. I know we had been doing pain protocols for a number of years. I've heard different kind of aspects and different kind of opinions on pain protocols, but for us, we had a number of patients rather, that it actually did make some sense. We also just basically started providing some general reporting. That 20.6 scripts per 100 visits felt like a lot. We brought it out to the team. We started just kind of talking about this. And of course, we actually did break this down to the individual department. At that time, we had two departments working. Or two departments in our system rather. And with that, you can see we ran right around 16 to 17 scripts per 100 visits. And just the mere fact that we were started taking a look at this, we already started seeing a little bit of that Hawthorne effect, the change that happens just because you're looking at something. And the fun part about this, our team is comprised of lots of different folks. You got the early innovators, you got kind of the middle group, and you got the late folks, if you will, the laggards as far as to make some of these changes. And just the fact that we started even talking about this, of course, we saw this kind of throughout our specialty, and even we started taking a look at some of the basic data, just kind of overall data. We started seeing folks started making that change. And I joke, sometimes I'll joke about that. These kind of folks, all you need is a little feather. You just need a little something to kind of push them in the right direction, and they'll start taking a look at their practice a little bit differently. And next time they write that narcotic script, they'll slow down and maybe take a look at it just a little bit differently. And the fun part about this is 2013 resulted in just a little kind of a downward slope there. And I know we had a little uptick at the end of the year, but we actually got for an overall average for the year right around 17 and a half scripts per 100 visits. So we were thinking, okay, actually things are pretty good. Now, what do we got in store for 2014? Well, that was a big win for us. 2014 and really, we had a number of years here that were pretty large here, and we knew iStop was right around the corner. That's that prescription monitoring program. I believe the legislation went in August, and it essentially went live in 2014. And for this, if you write a narcotic prescription, you're required to check the prescription monitoring program prior to doing it. And the nice thing is it didn't necessarily bring us to a screeching halt in the emergency departments because we actually were able to get a caveat. So anytime we were writing a script for less than 5 days, and as long as you were working in the emergency department, you could actually circumvent that. It did not require checking of the iStop program. Now, back when it came out, pretty clunky. And actually, if this would have been required in emergency medicine, it would have been really detrimental. And even nowadays, it is pretty clunky. And I took some screenshots of the process. So this is our HCS system. You basically have your own login, which is a bizarre, some initials and some letters, some numbers there, as well as a password, which we have, feels like 4,000 passwords in our life. So just to find the system, you generally have to open a web browser. You got to get your web page. So we got at least 2 clicks here. We get down into it. You got the prescription monitoring program. Click into that. Of course, you got to type in the patient's name, date of birth. That makes sense. Yep, and we got to abide by those guidelines. Of course, I have redacted information. There is no PHI here. We're now down into the making sure. Are you sure you really want to look at this person? Yep, we want to look at this person. So we're now in the neighborhood of 6 to 7 clicks. And in this case, we had no results return on this patient. But you got 6 or 7 clicks. You got a new password that you don't always use. You got to keep looking it up at times. You also got some different things that you have to manually type in the patient's name. It is very clunky. And this is a great example of if you want to put in a process that's hard to do, you're going to see a change in behavior by the team. And we'll get to that in just a moment here. Um, and the, so the nice thing is that there are some locations that have figured out different ways to integrate their EMR to make this a lot more seamless. We're not there yet. We're actually, I'm hoping it's around the corner. We're not quite there yet. So we're still dealing with a relatively clunky program, but this is beneficial. And you will see a number of the providers who, if there are indications that the patient may need to have this kind of check for them to see if they've actually been getting other narcotics from other places they may not be forthcoming from, or forthcoming with that information, then this is something we can kind of take a look at, and the team will kind of jump in there. We, of course, continued our pain protocols and, of course, our general reporting. And the fun part about this, well, the sobering part is every now and then that you don't necessarily want to see regulation make a big change, because then you have to admit that this actually was something that we had something to take a look at. But iStop in and of itself really just dropped the numbers precipitously. We essentially, for that entire year, we actually now had an average of 9.2, but by the end of the year, we were running right around 6.9 scripts. And if you take a look at the very beginning, when we started even looking at this in January of 2012, you got a drop of almost 24 down to 7 scripts, essentially. So we definitely saw this make a huge change, and people were slowing down now, truly, because they didn't necessarily, even just this relatively minor hurdle, did start affecting prescribing behavior. And I think it also just reminded some of us that, hey, some of the stuff that we maybe even learned along the way wasn't exactly the right thing to do for patients. So the fun part about this is we saw that big and huge precipitous drop. And again, it's a reminder to me that if you put in a clunky process, you always change some behavior. So this is kind of stuff that we even take a look at some of the way we affect, or the way we approach our IT interventions nowadays to try to make it as smooth as possible. So 2015, we were like, we just saw that drop. We were down right around that, that 7 scripts or so, and 6 to 7 scripts per 100 visits. We were thinking, hey, you know what? Our job might be done. We dropped from 20.6 down to 9.2. We're in good shape. Hey, tell you what, let's just continue our general reporting, check mark in the completion column. Let's take a look, maybe moving forward further. I warned you, I am a bit paranoid, or a lot paranoid. So we did implement some iStop compliance checks. There were still some providers that were providing scripts longer than those 5 days. So we went ahead and just did some chart audits. So we actually took a look at every single script that was written each month, did a quick scan. We were able to do this with our help from our electronic medical record, did a quick scan for pill count, and any of those pill counts or those day supplies that were higher, we did some chart audits. And we actually had a few people that needed reminders kind of along these ways. But again, 2015, we thought we were on the home stretch. Hey, we've essentially cut our narcotics by over 50%. We're pretty in good shape. But unfortunately, what we saw was a trend in the wrong direction, where we actually had was around that 7 script per 100s. We actually saw ourselves slowly climb up to that 8 script per 100. So lo and behold, you take your eye off the ball. Obviously, things can continually potentially slide there. So for the overall average, I think for the year was 7.7. So we weren't necessarily completely celebrating, because again, we had seen that trend going in the wrong direction, and it was tough to really combine the overall year's average from the prior year, because you had 2, almost 3 solid months of heavier prescribing practices. So with that, we tried to figure out, hey, what is the next level? In 2016, I think we kindly realized a couple of big items here. We knew the electronic prescribing was coming down the path. There was talk about that in kind of the summer of 2015. And for those of you that haven't seen one of these in the past, these are those paper scripts that many of us kind of trained with. I think the narcotics were a triplicate, which you always had to get out of the special. For us, it was actually locked away in the Med Select or your Omnicell or whatever device that you use to get your medications. You had to write those things out, and we went to a pure electronic prescribing. Initially, we're like, we wondered how much this would affect behavior, and our concern was, it's actually relatively easier if you have the stuff set up in your IT world. It's relatively easier to write the script, and we were hoping that we wouldn't see a trend in the wrong direction. However, we wanted to make sure that we were hitting this from all different avenues, and basically making sure that we didn't take our eye off the ball and see a similar trend that had happened in 2015. So it was at that time we started taking a look at things a little bit differently and finally slowed down and realized and actually start talking with the team from a different angle and saying, hey guys, what's going on here? Like why is there, what can we do to kind of help prescribe things maybe a little bit differently, or maybe curtail these curtail prescriptions, because again we're running right around 7 to 8 scripts per 100. We thought maybe, hey, is this a lot, is it a little? We knew it was higher than the previous year or the previous early part of the year. Is there something that we can do to kind of help you out? And with that, we kind of continually heard kind of more resounding statements from the team. And of course, we're all practicing physicians too. We're in that situation where we were often stuck in the middle of some challenging situations, and we actually had almost the expectation within the House of Medicine with our medical dental staff and our local environment that the ED was going to be there to provide pain medicine for patients who needed pain medicine. So we would see patients who would be sent in by the primary care physician to get a narcotic refill. We would see them sent by the surgeon. Maybe they forgot to provide them that pain pill, their pain script after their surgery. We would see, basically, we kind of were the end all to ensure that patients were appropriately supplied with narcotics. Well, we all realize that that's not best practice. Best practice is those narcotics need to come from a single physician that they can help manage the patient's pain. So we got together as a group and went to our medical dental staff at several locations saying, hey, we need to help make it, we need your guys' assistance to help make a change. Many of the staff actually were very appreciative and actually understood. We had several folks that were a little bit more challenged with that and that they couldn't necessarily use us as an overflow. But we had a lot of support and we were able to make that happen. Embarrassingly, we also needed a different approach, even just from a journal standpoint, with the expectation on other departments within our hospital, including even our quality team, but definitely our customer service team, where in the past we actually had indirect and direct pressure to just make the patient happy, to just give them that script, because if we didn't, some patients would complain. Actually, not many patients complained, but we all had those anecdotes, and we all had those different kind of pressures along the way that even our customer service team would actually kind of chastise a little bit. But we had the medical staff on board. We met with the customer service team. We ensured that we realized that the good care does not equate to providing a prescription for a narcotic, and we started changing those expectations and getting to that point. The other piece was also our team was a little bit challenged at times figuring out, hey, when should I give a narcotic, when I shouldn't? I know where things are. I know that you say that you're going to support us when the customer service folks are pointing fingers. No, let's just try to get some things a little bit more standard, if you will. And what we basically then was the time, and it was probably a few years too late, and this is obviously many places have done it, you guys probably have done it yourself included, is develop an opiate policy. Now, I put a policy in quotations because it's not a formal policy. We actually have it as guidelines, but we treat it as policy within our department. And we wanted to ensure that we actually took care of this in a way that actually was presented to the patient. So we actually came up with it. I think we stole some of it from another upstate institution. We took some of their languaging, actually with their permission. We didn't completely steal it. I guess we borrowed it. And we actually basically took some of their languaging. We referenced the FDA black box and some of on the codones. We also referenced some basic parameters as far as some pieces of data that were available at the time. And what we did is we started developing a list of diagnoses that we would expect would not get a narcotic. And we didn't necessarily get too crazy here. We didn't talk about the different various fractures of the hand or the foot. No, we wanted basically mom and apple pie type stuff. We wanted things that were very simple, that we look around the room and 95% of the team would say, yeah, that diagnosis should not get a narcotic. And what we did is we actually had a list of probably about 20 diagnoses. We shared it amongst the team. We shared it amongst, we actually had several departments. We actually had a few medical directors at the time, and we shared it amongst our nursing colleagues and said, hey, this is a list of things that we would anticipate would not get a narcotic. And I highlighted a few of them here. And if you want our entire pain policy, welcome to kind of just shoot me an email. I include in my email at the end, and I'm more than willing to kind of share that. Chances are you probably have something that may be a little bit better. But basic things like sprains and strains, abrasions, contusions. We were given narcotics for urinary tract infections. They were fun, popular dental pain, and of course chronic pain, generally managed by a pain specialist or their primary care. We didn't want to continue to kind of muck with that, if you will. So for the most part, kind of mom and apple pie, we wanted to keep this very simple along the way so that we didn't necessarily have a challenge with this. And we didn't want to make this too cutting edge per se. But we wanted to ensure that when we actually provided a narcotic, that one of these things were avoided. And we got pretty picky on this. Again, my paranoia is we wanted to ensure that an appropriate diagnosis to warrant a prescription for a narcotic was included on that chart. And we realized that it doesn't always, the way we are viewed outside our departments isn't by our chart. It isn't by what's documented in the chart. It's essentially a bunch of numbers with a CPT code, an ICD-10 code now, and basically that's all you get from claims data. And we wanted to ensure that we were using appropriate diagnoses. That if a insurer was auditing at us, or internal quality team, or the local practice association for physicians or providers was evaluating us, that we would look above board and ensure that we actually are trying to kind of meet some of those metrics there. So again, some huge changes. We got the electronic prescribing, we got the expectation changes, and we had the policy change here too, or policy addition rather. We also did make some changes with how we're reporting things. We continued the iStop compliance from the previous year, but the general reporting, by actually ascribing the total departmental numbers, gave us a potential challenge. And this is actually this was actually our total roll up for 2015. I showed you the previous year's results, which were better. You can see, of course, one site was a little bit better even than the other. But the challenge is, if you throw numbers out like this to the team, remember, you got a whole squad of folks. They're very different individuals at times. And if you have a big number like this, so sometimes you have folks that can still stay in the denial phase. They can look at the next door neighbor or the next door colleague saying, you know what, it's Dr. So-and-so that's given all the narcotics. I only write narcotics when they're absolutely warranted. And by actually moving down more towards an individual level, we were able to show some folks that actually continually had higher rates. A higher narcotic utilization rate. Now, does this actually mean the person's doing something wrong? Maybe, maybe not. We did need to dig into a little bit more the patient populations and things like that. It's not uncommon. First excuse as they go through the stages of grief. My patients are sicker. I see higher acuity. I see more patients, so I give more. I have to give more medicines, or I see more fractures. I see more orthopedic. There might be some credence to that, but for the most part, this stuff generally washes out along the way. But the nice thing is, by actually using this is, we actually, remember, we had that initial departmental stuff that helped those early adopters and those innovators start making some changes with that little feather push. We needed that early majority, if you will. Those guys just needed a small nudge, kind of moving in the right direction. And what we were able to do then also is we took that data. We would actually start publicizing this data more frequently. And then we also took a look at on our OPPEs. That's the ongoing professional practice evaluation. And the way we interpreted that is, and the way we do that is every 6 months we do an evaluation with a provider. And we started tracking narcotic utilization rates. Initially, it was just kind of, hey, just so you guys know, this is where you are on this, where you are on your scale, where you are compared to your colleagues. And it was just a kind of a data point along the way. We didn't do a whole lot necessarily other than that. And the fun part about all these different elements, of course, we got the policy, we got the expectations from the medical dental staff, we got some reporting changes, and then we actually, of course, had the that ERX came online. When the ERX, sorry, that's electronic prescribing. Sorry, for electronic prescribing, we saw it did drop a little bit, but we saw, I think, a little bit more, a significant drop with the implementation of that narcotic policy, to the point where we're now running at that end of that year right around 4 scripts per 100 visits. I think the average, right around 6.4. So again, all moving in the right direction. And for those of you, if you wrote down our first 23.5, we now actually are sitting down. We're down almost 83% scripts. Now, I realize we're cheating a little bit because we're counting iStop into this, but this was all different steps and elements of the process to try to really take a look at narcotic utilization and such. So we felt pretty good kind of moving in this direction, and it got even a little bit, sadly exciting or good exciting, whatever, however you want to move, that as, hey, where can we actually truly go from here, and what's even the next element in this regard? And with that, 2017, we saw the other action required coming out of a New York State mandate, that with regards to the mandatory prescriber education. This was something that was now required every 3 years. We just actually re-upped it. You actually had to take CME. And I've heard of this in other states as well, but CME that was very well prescribed with the elements of the CME, what had to get done, what did it have to cover, and then we actually attested that we actually had completed that CME on the New York State website through the healthcare commerce system. We also, for those of you, we all kind of live in this different environment. If you blink today and or you wake up tomorrow, all of a sudden you got a couple new departments kind of working with you. So we actually had a couple new departments that were added late 16-ish and then one in 17, and we saw some different kind of processes here, if you will. And so now we actually had some more data. This is actually total. I think if we have a whole year's total, we're up to about 195,000 visits. We now have multiple different departments, and no big surprise, each department that wasn't necessarily used to looking at this kind of stuff before, we had to walk through all those stages of grief again. Some places and some individuals, of course, processed this a lot faster, but we eventually got to the part where we got everybody kind of essentially on the same path and moving forward. And the fun part, or the good part about this, is what you actually now have is even a bigger cadre of folks to ensure that we're kind of moving some things for there. This is and then the nice thing is what you now have. Actually, I gave you 2019 just because it was a little bit cart before the horse, if you will. But even the 2019 data, you can see various rates here, and we actually not only reported on the individual, we also compared them to their colleagues and basically kind of put this in front of them. And now we're actually truly working through those stages of grief that some folks, again, early adopters, will make some changes and make some adjustments. The folks a little bit later, I vividly recall a conversation that I had in the hallway one time. I had a guy that actually was still stuck in stage 1. He was on that left, almost the very far left-hand portion of the graph. And he's like, Keith, just cut the chase here. I know you keep sending this to me, and you keep saying, hey, your rate's a little high. Do you really think I have a problem? And I just kind of looked him in the eye, and I'm like, you actually are one of the highest utilizers. You actually almost twice as much the normal or average. You're actually 10 times as much as so and so and so and so and so and so. Yeah, I think you got a problem. I think you really need to slow down, take a look at how you're utilizing your the narcotics, and take a look at those diagnoses that you're using it for along the way. So we had some more in-depth conversations at the OPPE level. And for some of those folks, we did see some changes. So unfortunately, 2017 was a little bit of a wash here. We actually saw you see that little spike right there. That was actually because we had a couple of new departments that we were actually feeding our data in. And as a system, we saw our utilization rate go up. We chose to basically measure as a system and report it as a system. But thankfully, by the end of the year, we were right around that 4 scripts per 100 visits again. And then I think the average rate around 4.9. So even with that little bump in there, we still saw that continued trend, and we're still down about 83%. 18 to 19, pretty big years. You got, and basically what we were doing is we had worked through a lot of those stages of grief. We were just truly aligning the railroad tracks, if you will. We were coming up with a system alignment and expectations along the way. I saw kind of a question pop up asking about some of our MAT. This is when MAT really started helping, working in our area at least. I think Buffalo beat us a little bit to the punch, and we were shortly after that we were working our MAT program. We don't provide MAT prescriptions in the emergency department because we actually have an amazing resource with our behavioral health team who will provide a next day follow-up visit, a next business day follow-up visit. So we can give a single dose in the ED, and then the patient subsequently follow up the next business day with our chemical dependency colleagues. If it's over the weekend, we will sometimes give it, we offer the patient a second dose if necessary. But since we have the ability to have a direct appointment with an expert in the field, we don't provide the script out of the ED because for the most part, we can kind of work around it. We don't even have to. And then they'll go to their MAT appointment, and then they actually get evaluated even more in depth to talk about inpatient versus outpatient versus other types of intervention, and do they get on medication there. Realizing that, so that's where I'll probably leave Matt because that's I think another separate topic, but kind of continuing to dig into our opiate reduction techniques here. We started to take a look at things a little bit differently because we still had some folks that were kind of on the wrong end of the scale. And what we started doing is we not only tracked the individual rates, we actually started taking a look and tracking what we kind of described as those fallouts. We still had a number of providers, not a big surprise. It was generally the higher utilizers that had a number of quote fallouts on that side of the graph when they were using narcotics for abrasions or scrapes or things that were just a little bit bizarre when you're kind of reading the chart. And what we really needed at this point is, early adopters, you need that feather. You need a little bit of a nudge for the majority. And the later majority, I kind of joke around sometimes you need a little sledgehammer or a 2x4 to kind of get some things changing. And with that, we started actually tracking fallouts. This is actually 2019 data here. And actually, this is true data that I actually overwrote with fictitious names for those of you hopefully recognize. Hopefully, I have a team that recognizes. But there were people that had a relatively high number of, quote, fallouts or maybe inappropriate narcotics, but they were also the same folks that were on the high end of the scale. And we had a number of folks that needed that little sledgehammer to kind of move some things a little bit differently. We also added on in ED utilization because teams are smart and they figure out kind of workarounds. But we also were seeing some patients that were getting narcotics for some conditions that just didn't make as much sense while they're in the ED, but they didn't necessarily get a script. And then we constantly saw people coming back here. So with regards to that, we actually, again, we want a mom and apple pie. And what we stuck with for those was the diagnoses basically cycling around dental pain and then vomiting. Because for the most part, vomiting is very uncomfortable, but unless they had abdominal pain to go with it, I said dental pain. It's dental pain and vomiting. I think I said dental pain. Unless they have, from a vomiting standpoint, unless they have the abdominal pain to go with it, we wanted to ensure that we were just sticking with antiemetics for those patients. And we actually reported those for the on their OP as well. So with that, I gave you kind of 2 years. I smashed 2 years together here. We're looking pretty good on time. And what you can see is if you let your eyes blur a little bit, a continual kind of regression kind of going down. We got down to 4 for the overall average for the year, and we're down to 3.1 for the overall average in 2019. And then for those of you who want to really kind of take a look at this, this is down 88% from day one, essentially. 2020 has been kind of fun and interesting. We definitely wanted to take a look and figure out some different things. Of course, we continue to track rates, but we had just continued people that were on the wrong end of the scale, and we had some folks that were actually continuing to have these, quote, fallouts along the way. And we didn't necessarily want them to feel like they're getting pointed at. We just wanted to make sure that they were truly recognizing they're different than their colleagues. So as we were taking a look at this, and we wanted them necessarily, this wasn't necessarily, you couldn't keep using the excuse, well, medicine is an art. You got to realize, Keith, that patients aren't numbers. You got to make sure you kind of take this into account. But when we truly have data and trends that show they are different from their companions or their colleagues, then we really need to make sure we're doing the right thing. And I think from the other pieces, we also saw more and more stuff come out. The black box, even dating back to 12. For codeine in kids after a tonsillectomy. I realize that I don't think it's a big stretch, but for the most part, we probably shouldn't use codeine for kids in other situations too. So it may be kind of confined to that, but we basically took a look at that and said, hey, codeine is probably not the best thing for kids initially kind of moving out. And the fun part about this along the way is, our last time we used codeine for age less than 18 was October 2017. We had somebody who did it by accident, and we basically provided some education at that time. And by tracking along these ways, it was actually mid 2019. My boss was like, Keith, you remember this FDA black box? Oh my goodness, I just saw this. What's your guys' performance with regards to coding? We had that data shield ready, locked and loaded. I'm like, yeah, we actually haven't done it since October 17. It was so-and-so. We've educated them. And this is actually part of our education as we could bring in even new providers too. And then we also took a look, those folks that had a continuous trend or have a continuous trend for fallouts, we now have actually implemented a few FIPEs or a focus professional practice evaluation to really say, hey, you know what? We've been talking about this for a number of years. We are serious that this is a concern, and we have a concern for your prescribing practices. I know you may not have heard from anybody else at a different level, but you are different from your colleagues, and we just need to make sure that we're kind of working together to make this happen and make this a little bit better. And then the other thing in 2020, we've actually been working on pretty hard, was with regards to our morphine sulfate immediate release utilization. Along the way, I think some of the recommendations by several of our folks in our community are to avoid the codones due to their euphoric tendencies, as well as the tendency for kind of potential addictive properties later on. So we've actually made a concerted effort to move to morphine sulfate in all appropriate indications. And as you can see, we get kind of a different spread. And we actually, the one place is at urgent care, they only had one script, so that was why the 0%. But we've seen kind of a continued trend moving this up, and we even drill this down to the individual level. So we're actually talking about at their OPPEs now, their morphine utilization there. And since we have been working this for a while, we've been talking with some of our colleagues throughout our hospital. We also actually put this as an external quality metric. One of our local payers have different quality metrics for our hospital account or hospital contract. And so we actually we actually now have a goal, a narcotic utilization goal for which we're shooting for. And right now, as you can see, we're doing very well in 2020. Again, down 88%. So for those of you have written down or have a great memory, better than mine, we started in January of 2012, really at 4 pills per visit. We're now running right around 0.3 pills per visit. We essentially do the number of narcotic scripts in an entire year, actually less narcotic scripts in an entire year than we did in a single month back in 2012. So almost to some of the questions here, but this is often, when we see some of these external mandates, we see these often kind of a push against us. But I think sometimes we just kind of we just changed the talk track a little bit, and we just figured out, hey, how do we change that effort to kind of help pull this process while we got some of this pushing? So I stopped definite big change. E-prescribing, maybe some change. I think it was much more, I'd like to think it was much more some of our different approach with regards to our policies and guidelines. Mandatory education, sure. I think I think there's different approaches. I'm not. It's always tough to be kind of imposed upon CME when we should be taking care of that ourselves. But it is what it is, and there are some potential benefits for some of our providers if they've not been watching this. I think internally, you definitely have to have that expectations, have that policy. You need to have kind of something to point at on the wall here. And this whole thing is, everything I've shown you there. This is actually fairly high number of hours per month as we track and we report, and then we subsequently intervene with folks. We want to make sure that they understand and they don't get stuck at the denial area, because we want to help them move forward. And there are times that we see providers that were taught, myself included, to write narcotics for things that just probably didn't make as much sense nowadays as we take a look at it, and now that we truly understand the potential negative outcomes for folks down the path. And then the other piece here is actually, this is one thing I blew along the way, is don't forget that each place sees different types of patients. Even, that's initial one of the excuses, and I kind of joked around as far as the denial and anger and bargaining stages, but we do see differences among sites. And lo and behold, we see difference in those patient populations, whereas our one site with a slightly higher script rate per 100 visits, it isn't necessarily because they have higher utilizers. You take a look at it, I guess theoretically you have higher utilizers, but they appear to be appropriate. They don't have higher number of fallouts, and they also see a number of more patients sometimes with kidney stones, renal colic, and things along those lines, biliary colic, that type of stuff. So we've now gotten into the part where we delve into these and we do a number of these different things and dig in. But variation is probably very permissible throughout, and because we do have different patient populations. So almost a 45 thing on the button. So we've got a chance to cover all these different mandates, joked around their stages of data grief, and subsequently talk about the yearly interventions and the results, as well as maybe a potential consideration for a system approach. And with that, I got to the question slide. I may flip back to show you data if necessary along the way. I am looking over at the Q&A, and I got folks actually asking about, did it include MAT meds? It did not. We actually, like I said before, we don't necessarily provide the prescriptions, and you probably caught that kind of along the way. Again, our behavioral health team have provided an amazing resource for us, and we only have, I think, 1 or 2 waiver physicians, but it's the requirement to prescribe is relatively moot in our area because we have that resource. Yeah. So I love this. So this is asking about, do you have a process to cover a provider from the community who have unplanned time? So we have been very, we do have a process. Yes, we expect them to look at their colleagues. Most of our local providers work either in a group or they work relatively closely associated with another group. And they've actually had call schedule, not just even an unplanned time, but during planned times, they have call schedules, and we'll lean on those folks to ensure that they are actually utilizing that and not putting the emergency medicine team kind of in a lurch here, essentially. So for the most part, we ask them to work themselves out. Do you work out with your dental providers in the community regarding rapid, prompt follow-up for dental pain? Yeah, great question. We actually have we have the opportunity. There are two main systems in our area. Both systems do have a dental clinic. There is also a urgent care dental option in our area too. So from a dental standpoint, for we limit to dental caries. We don't necessarily, we will not provide narcotics to. For the most part, we see more than that. If you see more than that, if you see dental abscesses and things like that, we do make that allowance, but we ensure that we have people following up with that. So yeah, we do have that resource. I think dental care is always a bit of a challenge no matter where you are, but that's kind of our current plan. Oh, I like this. How do you collect prescription data? A ton of elbow grease. We actually, and the reason we actually made this endeavor is because we had flipped over to a different EMR, which we were able to kick out that data. So every month, I run the narcotic scripts. So we have been able to figure out there are different course electrons in there or whatever numbers in there that basically lets us I know all the scripts that I wrote last month, and then we quickly whittle that down. So we actually do some antibiotic utilization reporting and things like that as well. We actually track fluoroquinolones very closely, but our narcotic stuff comes out. So it probably took us a good 2 or 3 months working with our reporting team to really get a clean prescription data. And with that, it is a relatively high amount of elbow grease. So actually, we will go through and scan the diagnoses. And actually, we have a clinic. I have the luxury of having a clinical analyst who does a really good job and can be trained pretty well on this. And then I do a quick scan afterwards. And then once we take a look at that, basically two eyes have touched it. We kind of cement it, and then we send it out to the team. And every now and then somebody catches something that we missed or did something erroneously. You see a corresponding decrease in, yeah. So I'm sorry. The question is, I'm sorry. I'm reading quickly. I'm not sure if you guys can see the questions or not. So I should be reading these out. So question, did we see a corresponding decrease in opiate overdoses and deaths? The answer quickly is yes. But that is limited by what comes into the emergency department. Anecdotally, our community is still having a challenge. And it appears that we've actually seen folks along the way that actually unfortunately expire before they come into the emergency department. So, but what we've seen, the folks that actually get into the ED, we have seen a decreased number of deaths. The community data is a little bit more challenging to get, and I can't necessarily pull that off. One of the things I want to play with, and as I was kind of sitting down and thinking some of the stuff through here, what I want to do is actually take a look at folks that we've seen for an opiate overdose. And actually go back and take a look at if they ever got narcotics kind of previous or before they started having overdoses in the past. But as far as deaths, that's down. Opiate overdoses, we actually are seeing down as well. How do we engage other departments to reduce ED referral? Yeah, sorry. How do we engage other departments to reduce ED referral for narcotic prescription? The answer is consistently. And as you guys know, if it's easy to do something, even if it's not the right thing, people will make it easy. And unfortunately, this was very pungent conversations with certain departments and attendings. For the most part, my tactic is I took it in front of the medical dental board. And thankfully, at that point, nobody around I presented the why we're doing this. And by the time I got to the ask and what we were planning to do, nobody was basically willing to jump up and down screaming that the ED should still provide narcotics for, I love my orthopedics, so I'm pick on them, the orthopedic team. You didn't see them kind of jumping up and down and doing that. So I had support from the CMO prior. I let my CEO know as well essentially almost at each location. We brought this in front of the medical dental staff, and we ensured that we were going to get their support. And then sometimes it was some very interesting conversations with individual primary care physicians, and they were quite exasperated. However, once we provided some education as to the reason why, it was a little tougher for them to continue to argue about it. And some of them walked away still disagreeing, but we walked away with a relative understanding. Are we using Narcan in the community? We have a great number of overdoses in that area. Yeah, from a Narcan standpoint, we actually we don't have the ability currently to give it out of the ED. We initially had that we thought we had the capability, but our supply was relatively limited a little while ago, and we also we had to ensure that we were keeping some finances kind of in a little bit in view. What we do for all our overdoses, our goal is we give them a script for Narcan. Actually, our Narcan is available over the counter in our pharmacies, and many insurance plans at no cost. But we give them a script, and if we refer them to our chemical dependency, they're also going out with a Narcan script as well. So our first responders have been trained, I think pretty much throughout New York State. I know at least in our area for sure, to administer Narcan as well. Yeah. Do you encounter much provider resistance to this? And what about patient dissatisfaction? Love the answer. Thank you very much, because I didn't get a chance to throw that in here somewhere. So initially, provider resistance, the late adopters, absolutely. There was resistance. Early adopters and middle folks, it was tough to argue that we're giving 33,000 pills a month. Even though we see a bunch of patients, I think there was initial middle section that was tolerating us. There was that upper section that was willing to go ahead and make some changes, and the lower part. But what we did is we did stage this. We had that general reporting, then individual reporting, then getting a little bit more invasive, if you will. Patient dissatisfaction. I have made an agreement with the devil. I had sold my firstborn, but I have raw data for 4 years. I think I'm now at the 4 years, maybe 4.5 years of Press Ganey data, which is I'm sorry, of our local vendor for customer service surveys. But I have discrete data that shows patients who got a script and who did not get a script. And you see what wavering things back and forth. Generally, the patients who got a script that were the frequency now is pretty low. So the end of that is pretty low. But I've seen that be patients who didn't get a script 1 year, their satisfaction was higher, and then it completely kind of flip-flops. But for the most part, it is not a continued trend. Patients who don't get a script are pissed off. Patients who don't get a script are generally pissed off because of other reasons. And we all have our anecdotes of that last argument that we had with somebody. Yeah, they might give you a bad survey, but we don't necessarily take a look at this along the way. And what we also did, and actually we did this in concert, we do track complaint rates per physician, and we actually report that on a 6-month basis. And when we brought this out, we wanted to ensure our team felt very supported. And if we took a look at the complaint, and most of the time it's very easy to tell, it was a little subjective, but it's relatively easy to tell if the patient had gotten a narcotic, like if the reason they were upset because they didn't get a narcotic. Now, if the provider was a jerk when they explained it, why they weren't given a narcotic, that was a little bit tougher area. But if we could take a look at it, a new physician joined our team, I think in 2016 or so, and that was Dr. Narcotic. We attributed all the complaints to Dr. Narcotic so that we didn't necessarily hold our team responsible for basically trying to follow what we're trying to do. Any issues with pharmacies carrying morphine IR? I tried when I started at my new hospital, but had several bounce backs with my partners. Yes, there were some initially. Before we went with the morphine IR, we did reach out to our high volume or higher volume pharmacies and gave them a heads up saying, hey, this is a new practice. This is the reason why. I even just got a pharmacy thing last week. The challenge with morphine IR is making sure you're staying under the 50 milliequivalents per day. So you got to be careful with that piece, because they'll call you and they won't be able to fill a script. And interestingly, when I said, hey, can you give me a recommendation here? They're like, well, just use oxycodone. I'm like, yeah, that's what we don't want to do. There was some issues, but we gave them a heads up. And then subsequently, since this was a relatively hospital and system procedure, we actually did reach out to our counterparts in the other system to let them know that we were doing this. And we've actually been able to change some of basically the formularies or the stocking at the pharmacies. And our medical community in 2014 had a big emphasis through the society to encourage reduction of opiates. This was sadly interpreted in many situations as being encouraged to stop opiates, throwing many dependent chronic pains patients to the street. Yeah, had unfortunate outcomes. Please comment. Yeah, we we didn't stop narcotics. We basically ensured that patients were following up with their single point of contact, and we were concerned about this as well. But we were seeing a number of these patients that had used had made maybe moved from chronic pain to other type of properties, and that were better suited with a continual physician managing that. And we actually still have pain protocols. When they come in, we will, if we work with a pain specialist, we will actually set up pain protocols with a couple of patients where they get certain dosing, and they actually might even get a script. For the most part, that's extremely rare. They actually are watching kind of thing from our standpoint, and if necessary, we give those guys a quick call to make sure the script is called in. So for the most part, we shared the concern. We didn't necessarily want to completely eliminate. That's why we kind of came at it a little bit differently. Some of our colleagues have done more narcotic-free EDs. For the most part, it's not exactly always narcotic-free, but that's a kind of a different approach. And I think our goal was to kind of hit this a little bit that in between there. I like it. Do we have a list of participating pharmacies in the Hudson Valley? Not yet. If you shoot me an email, I got it at the end. I can all our big ones up here actually follow. I'm a little bit farther from the Hudson Valley. Medical community adopted a uniform medication agreement which could flag in the ED medical record, so the ED providers were aware of individuals that had ongoing prescription for opiates. Cool. So that they weren't overdosed and not flagged with a dirty UA. Okay. How did your system prescribe chronic opiate analgesic patients? So the main process what we do here is we ensure that the chronic folks, if they got to the part or that threshold to get a pain protocol, then we will take a look kind of from that standpoint. Probably the majority of folks don't necessarily always cross that threshold. For the most part, if we have chronic pain of anything, we sit down with the patient, and it's actually it actually takes a little bit longer. We actually have to sit down, talk with the patient as to why we're not doing this, the reason we're not doing this, and for the most part, we have relatively good success with our patients. They kind of understand that. Of course, 5% of the time you got somebody who doesn't necessarily want to hear that piece, and they're a little bit less likely to do that. But I think for the most part, when we see those chronic opiate utilizers, we have a great behavioral health team with the chemical dependency to ensure that they are tied closely in with that team. So what we will do is we will make sure they get early referrals. Just because you don't have to get a referral just to be in withdrawal or after an overdose. We will actually give those referrals even for these kind of folks. So the best part about it is with those next day business appointments, which is phenomenal, we can get those patients seen relatively close to real time. So it's been very helpful. Do you have a list of pharmacies in the Hudson Valley that are part of iStop? So it's my understanding. Wow, I guess I might be making a wrong assumption, but it's my understanding that any narcotic prescription is going to be reported within the prescription monitoring program within New York State. So if it's still within New York State, it was my understanding that the pharmacy has a regulatory obligation to ensure that that goes in. I'm going to go double check my facts on that one, but we have not seen that necessarily issue. We, of course, have issues where if somebody is crossing state lines, sometimes those can be a little bit more variable as far as what we're seeing that. But it was my understanding that all pharmacies must actually cooperate with this as it is regulatory. So I think the questions have evaporated. I'm checking the Zoom here. Mary, I know you just came off mute. Help me out.
Yeah, no, I think we're done with the Q&A portion. Thank you everybody for your participation in the webinar today. And thank you, Dr. Grams. You'll see his email address here. Everyone who registered for the webinar will be receiving an email from me shortly with a recording of today's webinar, along with the PowerPoint slide and some other information about some other webinars in this series. So thank you again, Dr. Grams, and thank you everybody for participating today.
Great, thanks.